due to infection due to PID. And this obstruction can cause interference of the fertilized egg coming to the endometrium. But there's a good treatment. If the PID causes multiple adhesion and the kinking and tortuous of the fallopian tube, a simple laparoscopic surgery can cut all those adhesion and make the fallopian tube free from any tortuous or kinking or any kind of obstruction, and the fertilization will take place. Yes, it helps a lot. That's why we need to understand the fallopian tube very nicely. A lot of patient comes with the disease of the fallopian tube itself. A lot of people, girls may have infertility because of the fallopian tube problem. Okay, so we understood that fallopian tube has 4 parts from inner to outwards. There's a connual part, isthmal part, ampullary part, infundibulum part. And the infundibulum has fimbriae, multiple fimbria. Okay, and like a tentacles. The connual interstitial part or connual part is the narrowest part. Connual ectopic pregnancy can develop over here. The fertilized egg or morula or blastocyst can be stuck in the connual part. That is a connual ectopic pregnancy, and it is dangerous because when it is ruptured, it ruptures also with the uterine artery that is very close by. There is tremendous amount of hemorrhage takes place. Isthmus pregnancy, ectopic pregnancy may take place, and the ampullary part is the wider part and it is the longest part, and most of the time fertilization takes place here, and ectopic pregnancy can develop over here if the fertilized egg fail to go to the endometrium. Okay, and the infundibulum part is the outermost ring area. And we learned that it has a serous 3 layers in the wall. Serous layer is the outermost layer, muscle layer is the middle layer, and the mucus layer is the innermost layer. And if we draw the cross section, yes, of the fallopian tube, then it is the outermost layer, we call it serous layer. And then muscular layer. Muscular layer is a hypoechoic layer. The thick layer of muscle, and muscular layer, and the innermost layer is endometrial layer. The mucous layer. Okay, so this is mucus layer. And these are the cilia. We call it brush border. Okay, so sonographically, if you see endometrium, fallopian tube in cross section, the muscle layer is a hypoechoic layer, mucus layer is hyperechoic, serous layer is hyperechoic. Okay, so you need to remember, because of this muscle layer, muscle can have, it has a longitudinal fiber and the circular fiber, and it just make a peristaltic movement just like an intestine. Okay, so that movement goes accordingly when it wants from in to out or out to in. Okay, I hope you understood this parts of the fallopian tube and the layers in the wall of the fallopian tube. Okay, now let's see that fallopian tube usually 8 to 14 centimeter in length, and it is 1 to 6 millimeter in diameter. Okay, it varies person to person, and the how it works. How does it work? Okay, so now let me show you. During the ovulation time, this is the Graafian follicle. Okay, so this is Graafian follicle. This Graafian follicle release an egg, and the egg is released like this. This is the ovum. Okay, so this is ovarian ligament. Okay, and look, this ovary release the egg during ovulation, and this egg should be right away grabbed by the fimbriae, and this egg is taken inside. It's taken inside, and this egg, it is the biggest cell in the human body that you can see. It's just like a dot of a pen, ball pen. And in the naked eye you can see. And in the under microscope, definitely you can see. Okay, so now when it is taken inside and the sperm comes to meet the ovum, then the fertilization takes place, plus sign. Fertilization will take place. If this ovum is not taken by the fimbriae and the ovum is anywhere, why fimbriae you couldn't take the ovum? I couldn't move. Why? I am frozen. Why? There are some infection, band-like things, it make me fixed with some structure and I cannot move. I couldn't move to grab that ovum. Then what going to happen? The ovum is anywhere in the pelvic cavity, and the sperm is looking for the ovum. Where is the ovum? Because sperm knows the smell of the ovum. It has been taught by the Sertoli cell. It has been taught while they were in the epididymis. They know the smell. And if the ovum, even though here, if the ovum is not taken into the ampullary part, if the ovum is here, and it will be fertilized by this sperm. It will be fertilized by this sperm, and it may remain here in the pelvic cavity, because it cannot be taken into the fallopian tube, because the fimbriae are frozen, fused, fixed with something else, and there is no movement. It moves just like an octopus, but it couldn't move. That's why there might be an ectopic pregnancy in the pelvic cavity, or it could be on the ovary, it could be in here on the pelvic fossa. Okay? And even though this fertilized egg can bypass this fallopian tube, and it can be sucked into the peritoneal cavity in the abdomen. If the pelvic pressure goes up, then the abdominal pressure, intra-abdominal peritoneal pressure. So then along the pressure gradient, that fertilized egg, before taken inside the fallopian tube, it can come to the peritoneal cavity, and there will be abdominal ectopic pregnancy. Abdominal intraperitoneal ectopic pregnancy. And that pregnancy can get in on the intestine, on the mesentery, on the liver, spleen. Okay? So, you understood the functions of the fallopian tube, functions of the fimbriae, and the ovulation takes place, and the ovum will be taken inside the fallopian tube. If it cannot, then sperm will come out and will fertilize outside. It may remain in the pelvic cavity, and it causes ectopic pregnancy. Okay? And so this is the pathophysiology that I am discussing. And we need an intact functional fallopian tube. It's very important. Okay? And as I said, that fallopian tube is very prone to develop a lot of diseases, and one of the most common is sulfingitis, followed by hydrosulfins due to addition, obstruction, occlusion. Sometimes fallopian tube may be absent in one side, or maybe congenitally there is a synechia. Synechia means the inside gets fused side to side and causes a segmental obstruction. Okay? So that is important. And so that is a fallopian tube. I hope you understood the details of the fallopian tube. Okay? So sonographically we will not see it. That I am saying that unless there is a fluid collection due to disease and obstruction. Okay? So that good. And the fallopian tube can cause ectopic pregnancy. So in the literature it says 92 to 97% tubal ectopic pregnancy that takes place within the ampulla and the isthmus together. Okay? Simply in the ampullary part, maybe 94%, 93%, 94% ectopic pregnancy takes place over there. Okay, so good thing that there is a good treatment for the PID, and laparoscopic surgery is helping a lot, okay. So rest of the things we will discuss during the pathology section. So now I will talk about the second thing is the vagina. Okay, let's talk. Okay, just 1 second, let me check my camera. Yes, it's good. Okay, now anatomy of the vagina. One more thing, just I want to share with you that ovary is not only hanged by the ovarian ligament with the uterus, ovary also gets supported by the broad ligament and cardinal ligament. Okay, so it gets its artery and the venous passageway through the ligament, that is the cardinal ligament, and through which that gives the support of this blood vessels. Okay, and ovary is on the posterior wall of the broad ligament. This is a board test question. Okay, so now anatomy of the vagina. So usually if I draw the diagram, so then it will be better for you to understand. Okay, this is vertebra. Okay, fine. And this is front and this is back. This is abdominal wall. And this is bladder. And the vagina is here. Okay, I'm showing the reflection of the peritoneum. Okay, so this is anterior cul-de-sac, this is posterior cul-de-sac. So this is bladder, this is the uterus, and this is rectum. This is vagina. So vagina is posterior to the ureter. Vagina is not ureter, is a bladder neck and the urethra, posterior to the urethra. This is urethra. And the vagina anterior to the rectum, anterior to the rectum. Okay, and the vagina is in the middle. There are three openings, 1, 2, 3. So urethra is anterior, middle is vaginal opening, and the posterior is anus. So this is anus. And there are two cul-de-sacs that you know. So this is anterior cul-de-sac, and its name is also vesico-uterine pouch, and this is posterior cul-de-sac. And his another name is recto-uterine pouch or pouch of Douglas, and that is very clinically very important. Okay, we need to remember that. And now I will show you the vagina, how it is connected with the uterus and how it could be normal and it could be abnormal too, because there are some feature clinically patient comes with that. There might be atresia, vaginal atresia, we call it gynae atresia, vaginal occlusion, imperforated hymen. Okay, so vagina may need reconstructive surgery, and let us talk about that. Okay, so now okay, so this is vagina, right? So, external os, internal os, this is cervix canal. Again, you know this part, okay? Endometrium and the fundus, this myometrium and the body, okay? So now, this vagina is a membrane and the muscle.